Hello and welcome to the first in a series of 10-minute topics. We're going to be talking about arterial blood gases. And my name's Dr. Dan Halprin. So what is this, first of all? So we're going to be producing 5 to 10-minute chunks of material. These are designed to give quick guides to clinical topics. At the time of recording, all teaching has been suspended. So we want to give some relevant teaching, especially in areas maybe causing people anxiety or concern. This is aimed at everyone from F1s all the way up to registrars, any doctors are coming back from retirement, trust grades, everyone. Okay, and this is designed so you can learn quickly from your phone, your tablet, or your desktop as time permits. So the aims of this session are a few reminders for interpreting blood gases, some top tips. There is an emphasis on respiratory failure. We're going to consider some slightly more complex cases as well. Okay, so first thing to consider is the list. The first thing I really want as a take-home message is, so someone has circled some numbers and then handed you a gas. Don't just look at the circled numbers, because that's a great way to miss some important stuff. Okay, so check all of it. So have a look on the right and you can see the order. I'm sure you're all familiar with this. Okay, we're not going to be using this particular gas, it's just an example. Okay, some crucial points before we move on, and if you remember nothing else, please remember these. Always check the patient identity, it's obvious but relevant. And in a similar vein, ABG or VBG, you need to know what you're looking at. It's really important to know how much oxygen they're on, and I would always check nerve center or the patient, even better, rather than just believing what's on the piece of paper in front of me. Make a special effort to cast an eye on lactate and glucose, as these can be missed when you're busy studying pHs and O2 values and so on. And a quick glance over everything else, just in case there's something else you could be missing. Okay, let's do some cases. So, case number 1, you called to AMU, and you got a new admission from A&E. It's a 66-year-old retired painter. He's had a fever for 2 days and been a bit short of breath. No past medical history, but he's been to A&E before on the weekends, intoxicated, and he usually self-discharges. Lives at home with his wife and sees his grandkids regularly, still. So he's not been socially distancing. He quit smoking 20 years ago, and he started feeling shortness of breath after going for a long walk at his local park. He was admitted on 2 litres of oxygen, and now in AMU he's getting more and more dyspneic, and the nurses have put him on 10 litres via a non-rebreather mask. When you have a look at his bloods, everything looks okay. He's got a mild lymphopenia. So here's his gas. Feel free to pause the presentation and have a quick look. So we're going to use a systematic approach, look at the acid status, oxygen and CO2 status, a peek at the electrolytes, and then his lactate and glucose and everything else. So the main issue here is his oxygen status. So a PO2 of 10.3 is slightly on the low side at room air. He's not on room air, he's on 10 litres, so there's a problem. So just because the value is not particularly abnormal does not mean the patient is okay. He very much is not. And note that his CO2 is normal. This is type 1 respiratory failure. Differentials based on his history. Given this is being produced during the COVID outbreak, I think it's fairly obvious that your number one differential should be, does this man have coronavirus? But just because patients are having coronavirus doesn't mean they're not having other things, so do keep an open mind. And consider his history and his risk factors. Okay, case 2. So we've got a 92-year-old female on a medical outlier ward, and she becomes unresponsive. She was admitted 6 days ago after a full, presumed secondary to a UTI. Urine dip is clear. medical history of vascular dementia and some transient ischemic attacks. She's got hypothyroidism, hypertension and recurrent falls. She's waiting for an increased package of care from BD to TDS, so she's been sat in hospital for a few days waiting for that and some new equipment. When you arrive on the ward, her heart rate is 119, blood pressure is a little low, no temperature, SATs again a little bit low, her resp rate is very much up. She won't communicate, but is agitated when you're trying to examine her. And you haven't met this lady before, so you're not quite sure what her baseline is. No one else seems to know. So again, take a minute. So we have here a mild acidosis, 7.33, and a low CO2. Base excess and the bicarb are both a bit off as well, both a bit low. And the calcium's very low, lactate very high. So think about what's going to be causing the low CO2 and the low calcium. And then think back to the patient's history and details. It's quite a wide differential, but think about what you think is going on here. So when we look at it, this is a metabolic acidosis. So bicarb and base excess are way off, and it's probably developing quite rapidly, and that's based on the history. You can't tell that from the gas. The lactate is the main problem here, and that's most likely driving the acidosis. The pH isn't that bad. Why do you think that might be? If we look above and we see that CO2 is very low, the calcium's very low, and we think back to respiratory rate because she's blowing off all that carbon dioxide by hyperventilating. That's very possibly due to pain. So my number one thing to rule out would be ischemic colitis or something similar, or severe sepsis. So we're looking at a full set of bloods, cultures, and I think a scan needs to be done fairly imminently, along with some fluids and antibiotics. Okay, case 3. So you are on CDU now. A well-known 68-year-old COPD patient, been in for 3 days with an infective exacerbation, clear X-ray, CRP neutrophils a bit up, so he's on doxy and steroids and a litre of oxygen. He's got no past medical history and he has stopped smoking. Good man. OBS have been taken routinely and his SATs have dropped to 84%. When you ask, the patient says he's feeling a bit more short of breath than before and he's a little bit sleepy. Heart rate slightly up, respiratory rate slightly up, SATs are a bit low. He's got a very mild temperature. So already we should be thinking about what could be going on. So just take a minute to have a look at the gas. This is a relatively quick case, not an unusual situation. A COPD patient suddenly dropping their SATs. This can happen if they go to the toilet or bathroom or go for a walk around the ward, especially when they're in the exacerbation phase of their admission. So the main things we can see on the gas here is that the CO2 is a little bit high and the PO2 is a little bit low. And what we really want to ask is the CO2 retention, the high CO2, acute or chronic? For this, we can look at the bicarbonate, which we can see is quite high at 35. And this tells us there's been compensation, so this is chronic CO2 retention. The PO2 for the patient probably isn't that low for them. And the patient could probably be monitored. So why is the potassium low? Or a little bit low? That's most likely due to salbutamol nebs. If they've had them in the last hour or two, that could push the potassium down somewhat. So this patient was swabbed and was proven COVID-19 positive. Now the reason I've put this in there is that whilst on the previous cases we've seen type 1 respiratory failure, and that is the pattern that seems to be most prevalent with COVID, with patients like this one that have existing respiratory problems, you may well see a type 2 pattern. So type 2 does not exclude COVID. An hour later, well, there's a part 2. So the patient's been swabbed now, and you're waiting for those results. And he's been put by the ward team on a non-rebreather mask with 12 litres of O2 and sent for his X-ray. X-ray shows hints of bilateral infiltrates. Patient comes back up and is now very drowsy. So let's have a look at the gas. We've got a pH that's borderline normal. We've got a pretty high CO2 and a high PO2. So what's going on here? He's now oxygenating pretty well, and perhaps a little bit too well, and we've pushed him into an acute CO2 retention episode. So that would explain why he's very, very drowsy. Happens quite commonly, this. So he's likely to be a chronic retainer, your classic 88 to 92% oxygen target patient. And he's been given far too much oxygen as a reaction to a SATS drop. So you fixed your O2 problem that probably doesn't need fixing, and you've created a much bigger CO2 problem. So now we need to try and get some of that CO2 off. So what do you do now? Well, the obvious thing to do would be to lower the oxygen, wouldn't it? And what you want is the patient to blow off a lot of that CO2 and get themselves back down to a safer level. If they're drowsy, that's not always so easy, and you can get stuck into a bit of a spiral, especially if they're on any other medications that might make the patient more drowsy. So that's a time to consider non-invasive ventilation. Okay, last case. A 61-year-old lawyer is brought into resus with difficulty breathing. He's just been to Hong Kong, been unwell for 2 days. Got a productive cough, severe rigors, bit of confusion, not passed urine for 12 hours. Not much in past medical history, bit of blood pressure, no smoking. He's hypoxic. He's breathing a little bit fast, and he's got a temperature and low blood pressure. Take a minute to have a look at the gas. So he's quite acidotic, he's got a high CO2, a low bicarb. What do we think? Is this respiratory or a metabolic acidosis? This is both. This chap's in renal failure, and we can see that his potassium's gone up, his bicarb's dropped to try and compensate for this metabolic acidosis. His lactate's up. This is all looking a little bit nasty. His bilirubin is raised as well. You can't diagnose liver failure on a gas, but I'd be getting some LFTs pretty quickly as well. This person is in trouble. This looks like multi-organ failure, secondary to a chest sepsis. So that's it for ABGs. Don't forget to always check your patient, BBG or ABG, how much oxygen they're on, their lactate, their glucose, and a quick look at all the other numbers. Good resource is the American Thoracic Society. The link's on the page. Very straightforward. For more stuff, if you have any topics you would like us to address, email me. Address is there, and we're going to be uploading this and any other resources we can get together onto the clinical education website. And finally, I would urge you to download the Doctor Toolbox app, which is being updated pretty frantically at the moment, containing guidelines, contact numbers, and guidance on sort of investigations and things like that. It's definitely worth checking out. Cheers.